So during our presentation today, audio and visual capabilities will be turned off for our attendees to limit distractions. We do encourage you to ask questions of our presenter. Please submit your questions using the Q&A function on the Zoom toolbar at the bottom of your screen. Click on Q&A, type your question, and hit send. We'll address these questions as time permits during the Q&A portion at the end of the presentation. We are offering CME social work credits and McBath credits for today's webinar. We'll have a slide up with the information about obtaining these credits during the Q&A portion of the webinar. We will also email the continuing education credit information to the attendees after the webinar today. So my name is Katrina Hernandez, and I am a behavioral health consultant with OPEN, the Overdose Prevention Engagement Network. The Overdose Prevention Engagement Network, OPEN, is a diverse team dedicated to improving lives and reducing harms of substance use. By engaging with individuals, communities, and organizations, we share education and resources to strengthen person-centered prevention, treatment, and recovery. With an overarching goal of developing transformative evidence-based solutions to reduce harm and stigma surrounding substance use, we work to support healthcare providers and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based services and resources. We offer on-call consultation services to connect prescribers to our addiction medicine experts who provide guidance for managing patients who have substance use disorders or complex pain and can answer both individual treatment and technical assistance questions. We offer expert-led education and training sessions. All of our webinars offer free CME, CEU, and McBath credits. And for our prescribers, all our credits also qualify for the DEA required SUD training. We provide MOUD training for physicians. And this year we are incentivizing primary care providers with $250 to complete one of our MOUD trainings to encourage confidence and willingness to help expand access to MOUD treatment. Our next MOUD training will be held on March 5th. To prevent new and persistent opioid use, OPEN established and continues to update evidence-based opioid prescribing and counseling recommendations. These recommendations are based on patient-reported outcomes after various acute care episodes and provide data to inform opioid prescribing. You can access more information about all of these services more directly using these QR codes or visiting our website. OPEN also provides tangible tools to reduce harms of opioid and substance use, and our hope is to disseminate resources to places that need it most. We encourage you to partner with us and apply for our programs. We offer a free library of evidence-based credible education materials for both patients and providers. Patient education materials can be co-branded for free and are available in English, Spanish, and Arabic. And provider education supports best practice implementation for primary care, acute care, obstetrics, pediatrics, and dentistry. We provide safe medication storage and disposal options. We assist groups all across the state in hosting local medication take-back events. We fund implementation of permanent medication disposal boxes for qualifying applicants, and we provide charcoal disposal bags and medication lock bottles for healthcare and community distribution. We also provide overdose rescue support. We fund implementation of naloxone vending machines and distribution boxes and offer naloxone administration training. These trainings are offered as live, virtual, or free online training courses. No planners, faculty, or others in control of content, either individually as a group, have no relevant financial relationships with ineligible companies. With that, I would like to introduce today's presenter. Elaine Doherty is a forensic scientist with the Michigan State Police Forensic Science Division. She has worked in the seized drug unit for 20 years at the Bridgeport Forensic Laboratory and has been the supervisor of the unit for 10 years. She is originally from the Upper Peninsula and received her bachelor's degree in biochemistry from Michigan Technological University. After teaching high school chemistry and physics for 5 years, Elaine spent 3 semesters at MSU in their master's program for forensic chemistry before being hired by MSP. And with that, I will turn it over to you, Elaine.
Like Katrina said, my name is Elaine Doherty. I've been with the state police for 21 years now. And number one, I love my job. I think it's a really fulfilling job, and it's interesting because I get to do a variety of things. So what I want to talk to you guys about today are just what we're seeing in the laboratory samples we test. We have 7 forensic laboratories across the state of Michigan. We vary in size from the Marquette lab has around 8 people, all the way up to our larger labs, Grand Rapids, Lansing, Northville, that have somewhere around 50 to 70 people at them. We have a variety of different services we offer, from firearms analysis, fingerprint analysis, biology, DNA. And then we also have our seized drug unit where we analyze samples that police officers think may contain drugs. And they can seize them and submit them to the laboratory. And then, as part of Michigan's state constitution, forensic services are provided free of charge to any police agency within the state. So it includes local police departments, sheriff departments, the state police posts, and then also federal agencies. So we actually get a significant amount of evidence from the ATF and the FBI. So just a little history of where kind of a presentation like this comes from. Ever since I started in this job, I've thought that we had all kinds of really good information to share that people could find useful, but I really had no avenue to share that information. So as time went on and as my role kind of changed within the Michigan State Police, I've been able to actually spend a significant amount of time collecting data and basically compiling it in a way that would be useful to different people. And one of the audiences that I found I really, really enjoy working with um, is the harm reduction audience. I really think that the information I have can be useful, and I think that that again is very, very fulfilling work. It's a little bit different avenue for the state police. A lot of people think that um, state police and harm reduction don't go together, but that's not true, and that's something that's actually changing all the time. So a little bit of limitations on the data I'm going to show you. So these are, this is a representation of what's being seen in the state of Michigan, but it is only samples that are seized by law enforcement, and it's samples that they've actually submitted to us. So I'm going to go over some general drug trends, and then talk specifically about opioid samples and what we're seeing in those samples. And then go on to counterfeit tablets, ecstasy tablets, and then some unusual encounters we've seen in Michigan in the past year or so. So this is a graph showing Q3 of last year, what we identified in the samples that were analyzed at our 7 different laboratories. So on the left there, you can see statewide percentages. Over 30% of the samples we analyzed contain methamphetamine, 25 or so percent contain cocaine, and then somewhere around 12% contain an opioid or more than one opioid. And then I have this broken down by our laboratory region. So Bridgeport, for example, the lab that I work at covers the entire thumb. It covers up to West Branch and then down to the bottom of Genesee County. And then Grayling is pretty much the northern, I'd say, third of the Lower Peninsula. Grand Rapids is kind of that whole west side and goes all the way from the border up, probably 2/3 of the way up the Lake Michigan coast. The Lansing lab is kind of that middle section from the Michigan border up to Isabella County or so. Metro Detroit analyzes almost exclusively samples that were seized in the city of Detroit. Marquette is almost all of the Upper Peninsula. Some of the eastern end do submit their things to the Grayling Lab. And then Northville is kind of the area surrounding the city of Detroit itself. So if we look here at methamphetamine, we can see that Marquette, Lansing, Grand Rapids, and Grayling all have a significant amount of methamphetamine, with Marquette having over 50% of their samples containing methamphetamine. If you look at our two Detroit area labs, Metro Detroit and Northville, you can see there's still not a whole lot of meth in those areas. Bridgeport seems to be kind of right smack in the middle. We get a lot of methamphetamine, but we definitely don't get as much as those other labs. And then cocaine is almost the inverse of methamphetamine. The labs that have a lot of meth typically don't have a lot of cocaine, and vice versa. And then we'll look a little bit more at opioids by region later on. So over time, the drugs that have been analyzed at our labs have changed. Methamphetamine has actually stayed fairly steady, but cocaine is one that we've actually seen a pretty decent increase in the prevalence, and it's something that most people don't think about. It seems like the media is full of information about methamphetamine, it's full of information about fentanyl, xylazine, but not much is said about cocaine, where cocaine really is, the prevalence of cocaine is increasing in Michigan. And then opioids are going down just a little bit. But if you look at those numbers, we're really talking about, 16% down to 14 or 13%. So it's not that much of a decrease. And that percent just means in proportion to everything else. So the actual number of opioid samples analyzed could be the same or even greater. It's just what else is happening. So methamphetamine, like I said, is the most commonly identified drug in our lab. In contrast to 5 years ago and more, almost all the methamphetamine we see right now is high purity, it's crystalline, and it almost all comes from Mexico. It's very rare to see a meth lab anymore. In the state of Michigan last year, I think there were between 5 and 10 meth labs. And that compares to 7, 8 years ago when there were over 400 meth labs. So typically, methamphetamine is smoked, but it can be snorted, injected, or ingested. I think one of the reasons for the rise in popularity of meth is how inexpensive it's become. When people were making their own methamphetamine, if they were selling it, which a lot of times they weren't, they were actually just making it to use themselves. But if they were selling it, it was usually at least $100 for a gram of meth. And now, if you're buying a gram of meth on the street, you're going to pay about $40. And as the quantity goes up, it obviously gets cheaper by the gram. So even in the middle of Michigan, you can buy a pound of methamphetamine for about $2,000. So if you break that down by gram, that ends up being somewhere in the neighborhood of $4 for a gram of methamphetamine if you buy in quantity. As you get closer to the southern border, that price drops even more. You can buy meth in Los Angeles for $350 a pound. And if you cross the border into Tijuana, it's about $150 a pound. So very, very inexpensive. The Mexican cartels have kind of perfected their methods of making meth, and so it's very, very cheap for them to make. And it's also very profitable for them. So when methamphetamine is made in Mexico, it's often smuggled across the border in commercial vehicles. These are just a couple examples of how it's smuggled. I thought the peanut one was very creative. And then kind of the newest thing they're doing is smuggling methamphetamine over the border as a liquid. So they'll dissolve the methamphetamine in water and then put it in some kind of vessel, either in this case, trying to mimic what looks like cooking oil, or sometimes it will be mimicking uh, tequila or some other liquid like that. They'll also transport it in the fuel tanks of commercial semis, and they're actually smart enough to put a layer of diesel fuel on top of the liquid meth. So if a sample from the tank is taken, it comes back as diesel fuel. Some other creative ways I've heard meth being smuggled is an insulated semi trailer where the spray foam insulation was about 40% meth by weight. So once it crossed the border and got to its destination, they just were able to take the foam, the spray foam out of the trailer. And then literally, if you put it into water, the foam stays solid, but the methamphetamine comes out of all the small little pores in the foam. Cocaine, like I said, seems to be increasing in popularity in Michigan. Powder cocaine is definitely a lot more prevalent than it used to be, but we do still see some crack cocaine. One change over the past, I don't know, 5 years or so is that both powder cocaine and crack cocaine are very high purity. We're talking 90, 95+% pure versus 10 years ago, it was probably about 40 to 50% pure. Cocaine is commonly smoked or snorted. Less commonly, it is injected, but occasionally we do see it in a syringe liquid. So cocaine also is, you'll see a common theme here. Cocaine is also trafficked across the border from Mexico or brought in from some of the Caribbean islands. And it's all managed by the drug cartels in Mexico. So you can see the YouTube brick on the bottom left. That's a kilo of cocaine. So if you think of a hardback novel that you might buy at the store, that's about the size, maybe a little bit larger than that. So they're really not very large. And a lot of them have these impressions in them, almost like a branding of the brick. I just read an article today that there's been a surge of cocaine seized at the Canada-US border in commercial semis, but it's going from the US into Canada. So we're being the source of drugs for Canada, but ultimately those do originate from the southern border. So hallucinogens are an interesting category of drugs. There's a whole bunch of different drugs that fall under this kind of category. Psilocin is one that I think is really interesting. It's one of the active ingredients in hallucinogenic mushrooms or psilocybin mushrooms. And you can see just in the past few years, the number of mushroom samples that we've analyzed has almost doubled. And if we go back 10 years to 2024, we only analyzed 67 mushroom cases that year. Some of these, most of these are in the form of actual mushrooms, but two things we're seeing a lot more commonly are mushrooms in chocolate bars. And then we're also seeing ground up mushrooms in capsules. And that's something that we basically, we saw mushrooms in chocolate maybe once or twice prior to a couple years ago, but we had never seen the ground up mushrooms and very rarely saw the mushrooms in chocolate. LSD is an interesting one as well. Its prevalence has definitely gone down. And honestly, I'm not sure why that would be. My theory on psilocin is that because marijuana is legal, a lot of people are going to the hallucinogenic mushrooms because marijuana might not be quite as exciting anymore because it's legal. What's the fun in taking something that's legal? So LSD has gone down, and some of it could be some of the negative effects of taking something like LSD. DMT or dimethyltryptamine seems to go in cycles. We still don't see very much of it, but we do see it occasionally, and that's one of the drugs that we see. We actually see extraction labs for here in Michigan. You just you Google it, you can figure out how to extract DMT from Mimosa hostilis root bark, and it's a very easy process. And then you have a very, very potent drug, DMT. Ketamine is also an interesting one because it's been in the media a lot, and there's been a lot of talk about its use um, in therapy. And we have seen an uptick in ketamine, but as you can tell here, statewide, less than 50 IDs in 2024. So it's still not a very prevalent drug. We are seeing ketamine mixed with fentanyl sometimes, though, which I think is really interesting. And again, it's not very frequent. It was around a dozen times or so last year, but it's just another kind of curiosity of why they would be putting something like ketamine into an opioid sample. Moving on to another category of drugs that are abused are the benzodiazepines. Most of the time, if we see one of these benzos, it's in a counterfeit alprazolam tablet. But we do see them kind of creatively sometimes. They'll be in a liquid solution. We'll see them occasionally in opioid samples. Sometimes we'll just see a powder with a benzo in it. And one of the kind of newer ways we're seeing it is in unmarked tablets. As you can see in the image there, on the internet, you can buy tablets containing different benzos. And bromazolam is one of particular interest because it is not controlled right now by the federal government. So what we're seeing are a lot of these designer benzos. So they're of the same, I guess, action and similar structure to benzos that can be prescribed, but they're tweaked just a little bit. And the federal government controlled 5 designer benzos last year, but bromazolam was not one of them. And so now that's become by far the most common benzo that we see, even more common than the prescribed benzos, believe it or not. We saw more bromazolam in the third quarter than we saw alprazolam or clonazepam or lorazepam or any of those prescription ones. So moving on to opioid samples, just wanted to pull out the prevalence of opioid samples in different areas of the state. In the Upper Peninsula, mostly because of geography, their drug source is actually different than most of the rest of Michigan. Most of the Lower Peninsula ultimately gets their drugs from the Detroit area, and some from Chicago. But the Upper Peninsula gets their drugs primarily from Chicago and also from Minneapolis. So a lot of times they will see things that are completely different than what we're seeing in the Lower Peninsula. And sometimes they're actually the first lab to see some of these new designer kind of up and coming drugs. As you can see, the Metro Detroit area does have the highest percent of identifications that are opioid samples. And then everyone else kind of falls somewhere in the middle. So when we see opioid samples come into our lab, most commonly we see them as a powder, and they can be anything from a white powder to a dark brown powder. Gray is very popular, kind of an off-white, tan. But we're also seeing colored samples that are opioids. So for example, purple, pink, you can see the photo there, purple, that's probably our most common colored opioid sample. purple, pink, green, blue. We've even seen orange and yellow. So just a whole variety of different colors. And I was at some training a few months ago, and they said that a lot of the fentanyl out of Canada is actually colored. And I'm not sure that that's the source of our colored fentanyl, but they said essentially all of the fentanyl coming across our southern border is a white compressed brick, similar to uh, the cocaine brick in the previous photo. But when they seize fentanyl in Canada, it's often colored. So fentanyl is also made by the Mexican cartels. But one kind of unique thing is that there are also places in Canada where it's being made. There's never been a fentanyl lab in the United States, but there have been several seized in Canada. Sometimes you'll hear in the media about fentanyl labs in the United States, but when they use that term lab, what they're really talking about is like a processing lab where they're taking a more concentrated fentanyl and diluting it with other things or even pressing it into pill form. So like I mentioned, opioids most often are powders, but they can also be in tablets. We'll talk about M30s later. And then syringe liquids. I'm pretty sure the most common way fentanyl is still used is by injection, but we do see a lot of evidence of it also being snorted. So this is some information. This is a good example of information that I think can be really, really useful for people in the harm reduction area. This is showing what the opioid samples we analyze are actually composed of. And you can see here of all the samples we tested, which is around 4,000 or so, only 1.7% of those samples were heroin with no other opioid present. So if people are on the streets and they think they're buying heroin, they're almost certainly not. It's almost always going to be either heroin and fentanyl mixed together or just fentanyl. There is a small number you can see there of other opioids, just about 1%. And those are either fentanyl analog called fluorofentanyl, or they're one of these new and up and coming opioids called nitazines. So we're not seeing either of those too often, but they are popping up occasionally. So as you can see, over 3/4 of the opioid samples we test are just contain fentanyl with no other opioids present. Looking at kind of the trend of like kind of beyond the transition over to fentanyl, back in 2020, we saw some new opioids. Brorphine was one of them. And then this was the start of us seeing these nitazine drugs in Michigan. Brorphine popped up. We only saw it a handful of times and then it just kind of disappeared, although other places in the US are seeing it again. Isotonitazine is an example of a nitazine, and across the US now there have been around 40 or so different nitazines that have been detected. Some are more potent than fentanyl, some are less potent than fentanyl. It really just depends on what their structure is. And to be honest, a lot of these are, when we see them in the forensic labs, a lot of times there's literally no information about them. We don't know how they're made. The DEA has a special testing lab where they actually try to figure out what exactly it is. Sometimes we'll be seeing something and honestly have no idea what it is, but we're pretty sure it's something, and that's where the DEA can come in and help us. So brorphine and isotonitazine popped up in 2020. 2021, we started seeing fluorofentanyl. So fluorofentanyl is essentially fentanyl with a fluorine atom on it, and it's actually a little bit less potent than fentanyl is. And one thing I found out at some training is that they think that fluorofentanyl could actually be an accident. That when the cartels ordered one of the starting materials to make fentanyl, they accidentally received the fluorinated precursor instead of the regular precursor. So they didn't even know that's what they were making. So that's kind of the prevailing theory on why fluorofentanyl popped up all of a sudden. We are still seeing it occasionally, but nothing even close to what we had been seeing back in 2021. 22 and 23, we saw fluorofentanyl persist, but then we started seeing these different nitazines pop up. And then 23, 24, we're starting to see a lot more of the fentanyl in pill form. Fentanyl in pills is kind of interesting because Michigan has traditionally been a powdered fentanyl or even a powdered heroin back in the heroin days area. And really, pretty much the whole eastern US. If you saw heroin or fentanyl, it was almost always in some sort of powder form. Where the western half of the country, if they saw heroin, it was black tar heroin. And if they saw fentanyl, it was almost exclusively in pill form. They almost never saw powdered fentanyl samples. So we're starting to see some fentanyl pills in the east side of the country. And it's been staying pretty steady for the past 2 years. So it's not something, it doesn't seem to be that the fentanyl in powder form is being replaced by the pills, but we are definitely seeing them. And then the western half of the US is seeing still primarily the pills, but they are encountering powdered fentanyl occasionally. And at one of the trainings I went to, basically the kind of the running theory on that is just what people are used to. People in Michigan are used to taking their heroin or fentanyl as a powder. They're not used to the pills. Where out west, it's just the opposite. They're used to taking the pills, and they're leery of powders. So fentanyl analogs, about 10 years ago, we started seeing a whole bunch of different kind of varieties of fentanyl. But they kind of each would pop up and then trickle off. And fluorofentanyl, like I mentioned, has stuck around for a little while now. We've been seeing it for a couple years. And the only other fentanyl analog we're seeing is occasionally a trace of carfentanil in a fentanyl sample. And we had 4 samples in the past year with trace amounts of carfentanil, and most of them were not even close to being enough to actually be identified. It was just by looking at the data, you could say, "Oh, I bet that's what this is." Interestingly, 3 of those 4 were seized in the city of Saginaw, and but they were seized in different months. So they weren't seized all within kind of a small time frame. They were spread almost identically a month apart. And then the other group of opioids that I've already mentioned are the nitazines. Sometimes we see nitazines by themselves, but most oftenly we see them mixed in with fentanyl. And then sometimes the M30 tablets, the counterfeit tablets, we've seen a handful of those that actually contain a nitazine and not fentanyl. There's a lot of work being done on these nitazines, trying to figure out their potency and basically how to predict their potency. Because if we find something we're pretty sure is a nitazine, the first step is to figure out what its actual structure is. But then we don't know, is it more harmful than fentanyl? Is it less harmful than fentanyl? And so there's a lot of work being done on that by some of the federal agencies. So here's a graph showing the prevalence of fluorofentanyl in Michigan by quarter. The blue line is showing samples that contain fluorofentanyl without any other opioid. And then the top line is showing fentanyl with fluorofentanyl mixed into it. And you can see how much that has decreased. And then over the past year, year and a half, it's stayed pretty steady. As far as public health goes, because it is less potent than fentanyl, It's not a super big um, public health, I guess, alert. If it was more potent than fentanyl, if something like carfentanil was coming up this commonly, I think that would be something of much more significance. Another hot button topic in the media is xylazine. So that's another thing that I've been keeping track of since early 2022. And looking at this month by month, you can see that our percent of opioid samples containing xylazine has increased. And we're hovering somewhere between 25 and 30% of our opioid samples containing xylazine. There still isn't a lot of xylazine in these samples. I think the East Coast of the US is seeing a lot more xylazine in their samples. They're also seeing xylazine in 100% of their samples. Every fentanyl sample they test in, especially like Massachusetts, every sample they test has xylazine in it, and sometimes it's 10 times as much xylazine as fentanyl. And what we're seeing is really small amounts of xylazine, or maybe the same amount of xylazine as fentanyl. The DEA has also looked into where this xylazine is coming from, and a lot of it is coming from either China or India. It's fairly cheap to order a kilo of xylazine on the internet. It's only a couple $1,000s. The why it's being mixed in is kind of the bigger question. A lot of users actually say they don't like it when their fentanyl has xylazine in it. Along with xylazine, we've been seeing some other dissociative anesthetics in our opioid samples. One of them is medetomidine, and we're not seeing it nearly as frequently as xylazine, but we're seeing it in about 3 samples a month. Xylazine is in about 40 samples a month that we test. And then the other dissociative anesthetic is ketamine, and in about, like I mentioned earlier, in about a dozen fentanyl samples last year, we also detected ketamine. So some other opioid trends, or kind of what I call myth busting of what the media tells you. We do occasionally see cocaine or methamphetamine in a fentanyl sample, but the media reports of fentanyl laced cocaine are just something that we don't really see. If we see cocaine and fentanyl in the same sample, it seems more like cocaine laced fentanyl, if that makes sense, where the cocaine seems like it's in there almost incidentally, like it's not in there on purpose. With all the media reports of fentanyl laced cocaine, what we think is probably happening there is that people are buying something they think is cocaine, and they take it as if it's cocaine when in actuality it's fentanyl. That seems to be mostly what's happening there. It's not necessarily fentanyl in the cocaine. Believe it or not, drug dealers have a little bit of, I hate to use the word integrity with drug dealers, but like if they're selling cocaine, that's what their customers want, and that's what they want to provide to them. There's not really a benefit to putting fentanyl in cocaine. It's usually a whole different it's a whole different thing to put something like a strong opioid like fentanyl in a cocaine sample, and the customers probably would not like that. So if you do hear those media reports of fentanyl laced cocaine or fentanyl laced meth, it's something that, like I mentioned, is probably them thinking they have one thing and it's actually another. This is a place where fentanyl test strips could be really, really useful. Someone thinks they bought some cocaine. They're not a very frequent drug user. They bought it for kind of a party on the weekend. Fentanyl test strips would be a great time, or this would be a great time to use those fentanyl test strips to see if they actually have cocaine or if they have fentanyl. By looking at them, you cannot tell the difference. They look identical. Another opioid trend are these complex mixtures. We see so many different things in our opioid samples. Up to 5 controlled substances can be present. We see different cutting agents that actually are psychoactive. So diphenhydramine, or Benadryl, is in almost all of our opioid samples. We're also seeing quinine in a large percentage. You can have caffeine, you can have acetaminophen, um, quetiapine or Seroquel we'll see in them. We'll see muscle relaxants. So just a whole bunch of different things in these opioid samples. And there's no consistency. There's no way to know what you have in there. And it's extremely rare for us to get a sample that doesn't have any other psychoactive substances. Like it only has one. So maybe it's just fentanyl with kind of nothing else in it, except kind of bulking agents. Usually the main quantity of the powder is some kind of sugar like lactose or something like that. So moving on to counterfeit tablets, I'm getting close to the end of my time here. In Q3 of 2024, we analyzed statewide 92 counterfeit tablet items. These are just some photos I found on the DEA website showing some different tableting machines. And we have had a few tableting machines found in Michigan. Although they typically were smaller than these are actually quite big ones that can produce a lot of pills in an hour. These presses can cost anywhere from around $500 up to $10,000 and more, depending on how many pills you want to press. And they can press up to 20,000 tablets an hour. We did see a sharp increase in counterfeit tablets a few years ago, but over the past 3 years, their numbers have really stayed very steady. Some pills, like I mentioned, are pressed in Michigan, but a lot are sent through the mail. This is something that COVID actually changed. Drugs used to be almost exclusively trafficked by courier, meaning passenger vehicle, commercial vehicle, that sort of thing. And a lot of drugs these days are actually being mailed, US Postal Service or FedEx or something like that. And pills are one of those things that get sent through the mail frequently. So these are our most common counterfeit tablet. Top right is a real M30. And actually the bottom right is also a real M30, but it's kind of worn down. And all the other ones are counterfeit. And of the 43 that we analyzed in the third quarter, almost all of them contained fentanyl. There were three or four of them that contained a different opioid. This is one place where I think education of drug users is really important. We went from people thinking they were taking oxycodone when they took an M30 to now I think most drug users know that if they're purchasing an M30, it's not oxycodone. It's probably going to be fentanyl or something like that. Another popular counterfeit are the counterfeit Xanax bars. We analyzed 36 of these in the third quarter, and all 36 of them contain bromazolam. Usually it's a variety of different benzos, but like I mentioned with the control status, this has become by far the most common one. So in this photo, the top left is the real one, and the rest of them are counterfeit. The red one, very obviously counterfeit, but there are pretty clear differences between the real one and the counterfeit ones. And especially in the forensic lab where we see these a lot, it's pretty obvious. S903s are another marking that's very common. Top left are real, and all the other ones are counterfeit. The font of the S, the 9 and the 3 are kind of key for determining if these are counterfeit, as well as the color. It's really, really tough to replicate the color of the actual S903s. The last set of counterfeits we're seeing are counterfeit amphetamine. We did see 13 of them in the third quarter. All of them contain methamphetamine. This is, for the other two, I would say most of what we're seeing are counterfeit of those markings, where with these ones, we're still seeing a lot of real ones, but we are encountering the counterfeit ones as well. And all the counterfeit ones we analyzed contain methamphetamine. Ecstasy tablets, this is another one where awareness for drug users, I think, is really important. Ecstasy tablets used to contain ecstasy or MDMA, and these days they contain methamphetamine. Most people, most college students, most people who go to parties think they're taking an ecstasy tablet. They probably have no idea they're actually taking meth. Some other novel drugs here real quick. PCP is not common in Michigan, but we are seeing it occasionally in correctional facilities of all places. Just a couple other oddball drugs here. Most of the time when we have these kind of strange drugs, someone ordered it over the internet. You can order all these things fairly easily. And they're not common. Usually we see them once or twice a year and that's it. And that's a good indication that someone's just ordering them online. The opium poppy seed pods and straw are pretty interesting though. Something we had never seen before until last year. And we've had, I think, 5 cases now of the dried seed pods and straw. Just some thoughts about overdose prevention here. I think sharing accurate information with high-risk populations is really, really important. The media doesn't always get it right. The DEA doesn't always get it right. I think having this actual what is in these samples is extremely important and can be useful for drug using populations. And also, if people are getting out of a recovery center or getting out of prison, they may know what drugs used to be, but they may not know what drugs are now. And so that information, again, could be very useful there. Another way that I think this data can be useful is that we basically have an early warning system for new substances. So we're very fortunate in the MSP labs that we're working on cases that were submitted less than 2 weeks ago. So we have a very short turnaround time right now for results. And so in a lot of cases, if a drug is seized today, within 3-4 weeks, the agency will have a report indicating what was in that sample. And it's a good way for us to also gather that information and share it. In the past couple years, I've made a lot of connections in the harm reduction world, and so I can push out this information as necessary if something pops up and it may be of public health importance. This last one I think is a big one, and that's the collaboration between law enforcement and public health interests. I never heard 10 years ago about law enforcement assisting people in getting help with addiction. And now there's really kind of a turnaround. And a lot of this is the education of law enforcement in the fact that addiction is a disease. And I've had many, many discussions with police officers trying to convince them of this. And some of them do listen to what I have to say, and I have changed a few minds. And when law enforcement can see something like addiction as a disease, it changes how they act and how they behave and how they treat people. And also, there's specific interactions. There's 2 programs. One is called the Angel Program, where anyone can go into a state police post and say they're looking to get into drug treatment, and the state police post has a way to set them up with someone who will literally walk them through the process and assist them, and they will not run them through the law enforcement databases to see if they have warrants. They won't search them. They won't do anything of that. They'll pat them down to see if they have weapons, but that's it. And another service very similar is Hope Not Handcuffs, where we're trying to keep people out of the criminal justice system and into treatment, which is really what they need. And then the last thing is drug checking services. Drug checking services, I think, were kind of unheard of. Some people still think that they're completely wrong, but that is a place where the public health interest can be assisted, and is a place where overdoses can be prevented. Sorry I went over. With that, I will take any questions you guys have.
CME will have QR codes and also links, so you can access the CME information by scanning those QR codes or by going directly to the links. And again, the information will be sent out to all attendees in a follow-up email. There's also some resources that have been put in the chat. So if you want to click on that link, it'll take you to some of the resources offered by Open. There is someone that has their hand up, so I'm going to go ahead and allow them to talk.
Yeah, hi. I just want to thank you for the information. It's funny that you say that the police today is looking at things differently. I am a recovery coach with lived experience, so I know what it is to be incarcerated, right? I know what it is to use it. Today, I'm a recovery coach, and I work for parole and probation. So the individual's getting out of prison, right? It's a different world after a long stay, right? And this information is so helpful to me. So my question is that can you please, if by any chance, provide me with the slides that you presented today? I don't know if that's possible, simply because I run a group out in the community for individuals that just are getting out of prison, and some are still actively using, unaware of the trends, right? And what they're putting in today's drugs. So it was just priceless information for me. I just want to thank you.
Oh, thank you very much. One thing that yeah, I can share these slides. Maybe Katrina, can I just send them to you?
You can. We also will be putting the recording on the Open website. So within a couple weeks, the recording will be up for people to view if they miss it or miss part of it or want to share it. So that will be available.
Another thing is, usually on a quarterly basis, sometimes every 6 months, I put together kind of a summary of what's being seen in the state. And I can share that with Open, and maybe they could add that to their resources page. So it would be something where it would continually be updated.
Yeah, that'd be great, Elaine.
Yeah, that would be to have that information. So yeah, absolutely, that'd be great. Thank you.
Good.
So there are a few questions in the chat. We will get to as many of them as we have time for. So one is, how does law enforcement track the origin of drugs? For example, how do we know meth is coming from Mexico specifically?
So that's a big question. I would say that that's not necessarily done at the state level. That's done at the federal level. There is, the DEA does a lot of that work. They have what are called signature programs, where they're actually looking at the drugs kind of down to trace amounts of what's in them and determining how they're made. And in some cases, they can actually determine where they're made. So for example, with fentanyl, they were actually able to determine that the two major cartels in Mexico are actually using the same sources for the fentanyl they sell. They don't have their own quote factories for it. They're using the same supply, and then it's just going in two different directions.
And how do we know that some of these drugs like psilocybin aren't partially a part of response to their antidepressant properties, like also ketamine? So their claims of antidepressant properties, is that why they're being used?
That very well could be. That's a whole nother world, and because we are part of law enforcement, we simply report if it's controlled or not controlled. But there's definitely that would kind of be on the law enforcement side to determine whether or not that person could have that substance legally. But that definitely could be a reason why more people are pursuing those types of drugs.
How often are you able to tell if pills are house-made versus not?
What was the first part? How often?
Yeah, how often are you able to tell if the pills are house-made versus not?
So, visually, I would say in the lab, we're probably 95%. But once we analyze them, we can almost every single time tell. And one of the ways is by when we crush it to do our analysis. Pharmaceutical companies spend a lot of time and a lot of money trying to formulate these pills correctly. And so a lot of times the counterfeits are a lot softer or a lot harder than the legitimate pharmaceuticals. So that's one way we can tell. We just see them so often that we get to know what the real ones look like, both color and the markings on them.
I think that's about all we have time for today. It is just about 1 o'clock. So again, the webinar has been recorded and will be up on our website. And all the attendees will get the CE information they will be emailed that in a follow-up email. And I want to thank everyone again for joining us. Thank you, Elaine, for a wonderful presentation. And I hope that everyone has a good rest of their day.